Prevention is worth several pounds of cure. Preventing infectious diseases tonight on Call with the Prairie Doc.
Listen to colistin, which is the last drug, so.
Good evening and welcome to On Call with the Prairie Doc. Spanning everything from a cold and flu to Ebola and Zika, infectious diseases can threaten individuals and entire populations. How we react to the threats and the work at prevention are key to how we deal with them. First, let's take a look at this week's Prairie Doc quiz question. True or false? After a regular flu shot, those older than 65 produce 50 to 75% less antibodies to the flu than do younger folks. True or false? Viewers who call in this correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you have 10 minutes to get your answer in. Joining us tonight from USD Sanford School of Medicine is Dr. Archana Chatterjee, professor and chair of the Department of Pediatrics, as well as Senior Associate Dean for Faculty Development. And also we have Dr. Jawad Nazir, who practices Infectious Disease Specialists, PC, in Sioux Falls. Thank you both for joining us.
Thank you.
So, Archana, tell us a little bit about, you're from where originally?
Originally from India, and been here in the United States since 1989.
Since '89, and you did your residency in peds and then infectious disease?
That is correct. I actually did my PhD first, followed by...
So a PhD in?
Neonatology, actually.
Neonatology?
Mm-hmm. Yeah.
Wow.
And then my residency in pediatrics and my fellowship in infectious diseases in pediatrics.
So that, and how long have you been in South Dakota?
3 years this time around. I actually was here earlier. After I finished all my training, my first faculty job was at the medical school in South Dakota. This was in the late 1990s, and I wasn't here very long, just a year and a half. But then I went back to Nebraska where I had trained, and then came back 3 years ago.
Saw the light.
Absolutely. The Northern Lights.
Oh yeah, that's it. So tell us a little bit about you, Jawad. You're from where originally?
So I'm from Pakistan. Originally did my medical school and a residency in internal medicine in Pakistan, and then came to USA. And here I did an internal medicine residency at University of Pittsburgh.
Again, because you have to do a residency in the States.
Yes.
So you repeated yourself. Did you learn more?
Well, I think I learned more in certain areas, but I think the residency back home in Pakistan, which is a third world country, a lot of exposure to difficult infectious disease problems, was very productive, and that is the basis for my interest in infectious disease. So I think that completes my, professional growth, in that sense that, I was training in Pakistan, where we third world country, with a different set of approach to diagnostics, and then training and practice in USA, where we have a different set of approach to diagnosis with more diagnostic evaluation.
You know, it's interesting. We speak to pre-med students before the show. We have them help us answer phones and so on and so forth. And the emphasis about the value of doing a careful history and a careful exam came out. I thought it was wonderful because as an older doctor, I think that's so important, so very important. So good for you. I was rooting on that comment. Well, I mean, but both of you do adult infectious disease, and you emphasize pediatric infectious disease. So let's just look at what are the things that you see commonly in a normal week, Archana?
The thing about our practice is that we never have common things that we see in a normal week. There is no such thing as a normal week in our practice. So you see whatever you get consulted to see. It might be a very sick patient in the ICU, in the neonatal intensive care unit, or in the pediatric intensive care unit, or it might be a patient in the outpatient clinic who's got a persistent problem or an undiagnosed problem that we're faced with. So our practice runs the gamut between very serious infections, sometimes puzzles which other physicians have not been able to figure out. Sometimes they're not actually infections at all, but it's a patient who's having chronic fatigue or fever that no one has been able to figure out the cause of. So it's very variable, and it varies day to day as to what we see.
Right.
So I think in adult population, somewhat similar, but I think, one thing we have to remember is that aging, we are aging more and more, and people are living much longer than before. But we are aging more at the expense of many newer medications, which are sometimes immunosuppressive, or organ transplantations. So the modern medicine has brought these things which makes us live longer, but at the same time would decrease our immune system.
And without our immune system, we have more infections.
So I think there's a broad range of infections we see in the hospital. That could be a complicated pneumonia who has landed in ICU. It could be a patient with kidney transplant who has an undiagnosed fever. It could be a patient with a joint infection with processes in, where you need to make a critical decision on treatment versus surgery. So it's challenging. It's a mix of both very complex cases and sometimes very simple cases where you see that the antibiotic use is not really necessary and you can get them out of the hospital.
Yeah. I love the idea of having an unknown. I mean, that to me, that was always in my whole experience, particularly in the hospital, the sick in the greatest fun, particularly if you can get the answer.
Yeah.
And sometimes the most frustrating when you can't. One of the things that I'm seeing more often, or I see as a big challenge for us, is a lot more people are getting artificial knees, artificial hips. I mean, they're going pretty quick to those nowadays. And of course, I think I blame the boomers, because we want to be active, we want to be able to do everything, and medicine can solve all our problems, right? And so boomers have that expectation, demand more. I want that artificial joint. But then sometimes they get infected.
Yeah.
Talk about that.
So I think, there is a big number of patients these days who get these joint replacements, but, a small percentage get infections, But the one who gets infections really get the complicated infections. So if you have a processes in your body that's just become a very tough risk factor for treatment of infection. For example, if in your finger or in your toes, or in your hand, you have blood supply. But when you put a prosthesis in, that's a foreign body in you, it doesn't have blood supply. So, the host defense system, which can clear any infection where there is not a prosthesis, is gone when you have a prosthesis. So sometimes, the treatment is very complicated. It may require a surgical procedure. That may require prolonged hospitalization. That may require intravenous antibiotics for an extended period of time. And all that can be associated with many complications, increased cost, and length of stay in the hospitals.
Right. I often, the big lesson back in the old days when I was there was you got an artificial joint or an artificial prosthesis of some kind that doesn't have its own blood supply, and it's an infection. It needs to go. You just have to take it out. Yeah. And I have a patient who had to live a half a year without a hip. The artificial hip was removed, and she's hopping around without one hip, and there you have it. I mean, that's what you have to do. Clear the infection, start again.
Yeah, I think, in most cases that is true. It also depends what type of bug caused the infections. Some have a higher virulence, but we say they are, more, likely to cause infectious complications like pus pockets or make you septic,
Yes.
Versus there are some bugs, which have a low virulence, those you can actually treat with antibiotics. These days I see that in most cases we do have good outcome, even if they have prosthetic joint infections. Yeah.
Let's talk about MRSA, though. This is right. It's not the only super bad bug, but the methicillin-resistant Staph aureus has been the first real resistant organism. Archana, any comment about MRSA? Is it more virulent than the old Staph and dangerous?
Yeah, so it depends, as Dr. Nazir was saying, on where the infection is. So MRSA has actually undergone an evolution, if you will, over time. The initial methicillin-resistant staph that we used to see was all in the hospital, and we would typically see it in the types of patients that Dr. Nazir was describing, who've already got underlying health conditions, who've already been on antibiotics, things like that. But around the mid-1980s or so is actually when we started to see these in the community. And the first inkling we had was when we had 4 cases in children who all died from this infection. They were otherwise perfectly healthy children, but they came in and they had this infection in their bloodstream, and nobody realized that's what they had. So because you need different antibiotics to treat MRSA. So that was in 1989, and ever since then we've been dealing with this organism. The common type that we see in children often is the type that causes skin and soft tissue infections. It's a nuisance infection. They keep getting these boils, and it does create problems for them because they miss school and their parents miss work and things like that. They're amenable to treatment. They're easy to treat. But then there's the more serious version of it, which causes bone and joint infections, infections of the heart valves and things like that, bloodstream infections. Those can be very, very serious and life-threatening. Yes.
Antibiotics have been a wonderful boon for humankind, but with their benefit comes danger. Danger from antibiotic-resistant disease, as well danger from life-threatening invasive overgrowth bacteria.
I can remember it was December 14th, and I had a sore throat on the right side of my throat, and just the right side, and had it for about 2 weeks, and thought, I probably should go get that checked, especially since I have grandbabies that I was helping take care of. Went to the doctor and got a prescription for an antibiotic, and I took it for 5 days, and on December 19th got really, really bad diarrhea. Finally, Monday about 5 o'clock, I called the doctor who had prescribed the antibiotic and just said, I've really been sick for the last 3 days with diarrhea. What should I do? And she said, how long have you had it? And that was too long, and so could I go to acute care that night? So I went to acute care, and they did a sample, and it was C. diff. So they asked if I would go over to the hospital and have a IV, just because I was so weak and almost dehydrated. So I went over and had the IV, and that kind of perked me up that evening. But they gave me vancomycin for the C. diff, took that for 2 to 3 weeks. Long story short, went back, got some more vancomycin because I had gone to the gastroenterologist and they had kind of taken me off of it too soon, so the C. diff came back. And that's when I took the vancomycin again and thought I was over it and wasn't. So went in, and then the doctor said, have you ever considered a fecal transplant? So thought this was kind of my best option. So went into the ER and did it as an outpatient in Brookings and had the fecal transplant, and fortunately have not had C. diff since. I would just be very, very cautious. Going what I went through is very difficult to get over and to get to feel back to yourself again. And, a sore throat or, like you said, a mild respiratory thing is something that you can get more rest, get a lot of water, do a lot of different things naturally without taking an antibiotic. I would strongly say that it would have to be quite serious before I would take an antibiotic. But not a fun thing. I missed a lot of important Christmas, New Year's, our baby's baptism in Wyoming. I said I just felt like I lost about 3 months of my life. So yeah, I would really think twice.
We answer your medical questions about prevention of infectious disease, treatment of infectious disease, anything infectious diseases. They're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. We need your calls. This is your show. Give us your call. So that was very interesting. So she had a C. difficile infection. What is C. difficile?
So it's a bacteria which lives in our gut. So we don't sometimes remember that we have a lot of bugs in our body. In our skin.
We have bugs in our body, in our skin, in our gut.
So we are full of bugs.
Full of bugs.
Yeah. So the lining of the gut is a defense mechanism to prevent infection, as the skin is a barrier to infection. So when we use these antibiotics unnecessarily, they kill the healthy bacteria in your gut. But they're not able to kill every bacteria, especially this Clostridium difficile, which overgrows then and start producing poisons or toxins, which are responsible for most of the manifestations of C. diff, like diarrhea and nausea
and sometimes death.
Death, yeah. No, I think the C. diff is a little bit different in a few aspects from other infections. It's an interesting story. One of the characteristics of C. diff is the recurrent nature of it, so it can keep on coming back, and patients can sometimes require multiple courses of antibiotics and may end up getting a stool transplant, Secondly, it can be very dangerous in elderly patients. So the studies have shown that if you get C. diff, if you are above 65, there's a higher chance of dying from the infection. So that makes a bigger sense.
Above what age?
65.
Wow. But the whole issue of immune-compromised state is a very important one, is it not?
Yeah.
So any other comments about C. diff? Do you see it in kids as much as adults?
Yes, so this is a very important point, actually, that these bacteria are part of our normal flora. They're part of the normal bacteria that are there in our bowel, especially in children. So in children who are under a year of age, we consider them to be part of the normal flora. And what sometimes happens is children will get diarrhea from some virus or some other infection. We have very powerful tests now that can detect this bacteria, and we'll get questions from primary care physicians saying, I have a 6-month-old who has diarrhea, who has C. diff. What should I do? And the answer is you shouldn't have tested for it in the first place, because this is part of their normal flora. Their diarrhea is probably from something else. Having said that, we are seeing more children because a lot of them are immune compromised. They have underlying medical conditions, short bowel syndrome. Those are children who are actually at risk for real infections with Clostridium difficile. And we have the same problem, only worse, because we have fewer antibiotics that we can use in children. We don't have all the antibiotics that you have available for adults.
Yes. I think as Dr. Chatterjee is mentioning a great point, but I think, we have learned from research and evidence that the major risk factor is exposure to antibiotics.
So there's two reasons to not use antibiotics when you don't need them.
Yeah.
One of them is you can cause this terrible overgrowth problem, and the other is resistance.
Yeah.
Let's talk about that.
Yeah. So I think resistance, it's not a new problem. I think it's just getting more attention in the last decade or so. But now, what we are learning is that, this resistance has become a major problem where we don't have drugs now to treat this multi-drug resistant bacteria. There have been some reports, about bugs causing urine infections or bloodstream infections where no antibiotic will work, so what we call CRE, which is the most extreme form of resistance we are seeing now. Now, I think we have to remember, if you get an infection, from an organism which is not resistant to antibiotics versus you get an infection from an organism which is multi-drug resistant or extremely drug resistant, what is the difference? Now, few differences. Infections are much more severe. Your chances of dying are much higher. Your chances of getting hospitalized and being in the hospital is much higher. And apart from all that, the cost of care is much higher.
So there's a lot of reasons. Now we've got a lot of questions. We appreciate your questions. Keep calling. But let's start in on some of these questions. And it seems to me that we need to be very sensitive to the overuse of antibiotics, and stewardship is a common thing. We should be careful to not use them unless we really need to. Of course, use them when we need them.
Yeah, exactly.
Absolutely.
I think what the antibiotic stewardship means is to use antibiotics appropriately. So it doesn't mean don't use them, or it doesn't mean use them all the time, but use them appropriately. And when we say appropriately, it means you need to have a reason to use them, and use them in the right dose right frequency and the right duration, so you don't treat them short, you don't treat them too long. I think what we see is sometimes these antibiotics are given too long, which leads to problems with resistance and C. diff.
There we go. Do you recommend using a special cleaning of the skin for children who are prone for MRSA, like bleach in the bathtub, that type of thing?
We actually have a protocol that we give parents to use
How
for
much
their
bleach
children.
for how much water?
It's a formula, I can't recall it off the top of my head, but there are a couple of different things we do. There are special soaps that we use first, because the bleach baths, and by the way, they are diluted bleach baths.
Yes.
They're very toxic to the skin, especially in young children, so we try not to use that if possible. Sometimes we will combine that with other what we call hygienic measures, keeping their fingernails cut short, because sometimes they'll scratch themselves and that's how they get the infection. Making sure that we change all of their laundry every day, their bedclothes, their night clothes, the clothes that they wear every day, and that those are cleaned and washed. So it's a number of measures that we recommend. It's not just the diluted bleach baths.
We used to say betadine. We used to say hexachlorophene. That we used to do. There was a new betadine. I've forgotten what it is. Alpuricin. I can't say it. But what are we doing now? Are we doing any topicals for people?
So we use an antibiotic, actually. It's called mupirocin.
There, that's the word I was looking for.
Yes, and we use it typically intranasally in the nose, because actually a lot of these staph bacteria are carried in the nose.
They're just sitting inside.
They're sitting in the nose. The baths are intended to wash off the bacteria from the skin, and the product we use is called Hibiclens.
Right.
Most of the time.
Hibiclens. So there's the other question. Whenever we have a cold or upper respiratory infection, people are blowing into their hands, to try to stop it from flowing, and then the result is their hands are all loaded up with the bacteria, and then you're at church and you're shaking everybody's hand, or you know what I mean? And my point is, hand washing is a very good idea, right? What about the hand cleansers versus hand washing? I've heard the hand washing is a must for GI illnesses, and the hand sanitizers work for respiratory. What is that? Am I correct?
Actually, the hand sanitizers work great for most infections. The one thing that we do want people to wash their hands for was what we were talking about earlier, which is C. diff, because that germ actually produces what are called spores, and spores are resistant to the hand sanitizer. So you actually have to wash them off.
But I think in a respiratory tract infection, it may be perfectly reasonable to use them. I think that's
and even for most GI infections, actually.
But C. diff is mostly in hospital settings. We encourage healthcare providers to wash their hands with soap and water.
And there's a certain odor that helps you diagnose C. diff. They say dogs can do it. My son who's a nurse in a nursing home, he said, I don't need to be a dog. I know that smell.
That's very hard to describe, but I think there's a special odor to that.
There is. Here's a question about pneumonia shots. There's been a new move now because Prevnar is available to adults older than 65. So give us the formula that one should do after you turn 65. What is the formula?
Well, do you want to take it?
That's fine. You can.
Okay. So Prevnar 13, which is the vaccine that is currently recommended.
Classically for the kids.
Yes. The original Prevnar was developed and licensed in the year 2000 to prevent meningitis in children, actually. So that's what the vaccine was originally developed for. It wasn't developed as a pneumonia vaccine. The bacteria are the same that cause meningitis and also cause pneumonia, so we kind of get a good side effect of reducing pneumonia with this vaccine. And what was found was that this particular formulation that's actually intended for children does produce better antibodies in adults, which is why it is now being recommended for use in adults, even though initially it wasn't studied or intended for that purpose.
I've heard something like 20 or 30,000 adult elderly lives are saved every year for all the kids getting Prevnar. That's proven.
That is what we call community immunity, or herd immunity is the more common term for it. That if you vaccinate the children, you will reduce the burden of this infection in the community, and they won't spread it to their older relatives
who are
or contacts.
Okay.
I think it also serves the bigger, concept, of preventing infections. So if you prevent infections, you will not use antibiotics, and you don't use antibiotics, you won't get resistant sensitive,
Yeah.
So I think in the overall scheme of things, it's a great tool to prevent infections. So you cut down antibiotic use too.
So this one talked about, do you recommend pneumonia shot for people 65 or older? Does it change from year to year? What strains of flu are using fighting this winter, and what is the health coverage for the flu shot? So the flu shot's paid for, right?
You can get influenza vaccine paid
Anywhere.
for by any health system for nothing. Actually, under the current law, the Affordable Care Act, all preventive care is supposed to be covered. So all vaccines actually should be covered.
All right. So now, we're recommending, if you've had the pneumovax that's 23 valent, right? 21 valent, whatever, 23. Then you should follow after 1 year and get the Prevnar, which is 13.
Prevnar 13.
But if you haven't had either one and you turn 65, get the Prevnar first,
And then
wait a
8
year.
weeks later, take the other one.
Correct, and the reason for that is because of the difference in the immune response. You get a better immune response if you follow Prevnar 13 with the pneumococcal 23-valent vaccine.
And they're not, I'm sorry.
Sorry, the patients who are immunosuppressed due to any reasons, or if they have chronic kidney disease or lung disease or heart disease, follow the same pattern, the
That's
Prevnar
correct.
first and then,
And we actually do it for children as well, who are over 2 years of age. Because children under 2 don't respond to the pneumovax, the 23-valent vaccine. So children under 2, over 2 who have underlying medical conditions,
They
we
get
do
it.
give them.
And so you don't have to be 65 if you have a lung disease, pneumonia, asthma.
you're
any
missing a
chronic
spleen,
disease, if you have any chronic disease, any organ disease, or immunosuppressed due to any reason, I think you should follow the same protocol.
Yeah. So this is interesting. With expanding world population, how much will infectious diseases increase? That's, to me, that's the whole story. I mean, remember the plague that struck through Europe, and it basically killed off half the Europeans, and the ones that lived probably were resistant. And then they came over, and and it wasn't just the plague; it was probably mumps and measles and all these other things. You've heard that story,
Right.
So then they come over, and it basically sterilizes North America because it kills 90% of the American Indians.
Mostly smallpox, but yes.
Smallpox,
a lot of different diseases. Measles, perhaps. It's unknown really what infections came from the old world to the new world, but clearly had a huge impact on the population here in the Americas.
Yeah, I think, things are changing, now this globalization, so, people are traveling much more. I think, 20 years ago, they were not traveling as much, but, they are traveling a lot and to different countries and with computers, and it's a global world now.
There's a risk with all this travel.
With all this, so I think when you travel, there's a high chance of bringing in infections, So I think it's very important to have awareness about the global aspect of infectious diseases, so you are well prepared to diagnose infections related to travel history. And I think Ebola and Zika, they're all important to recognize in a timely fashion for that reason.
And we lean on our health department to that. And thanks to Lon Keitlinger for his help in that regard.
Exactly, yeah.
Shingles can be a painful recurrence of the chickenpox virus. While it usually shows up in older patients, it can strike any age, and it can strike anyone.
In February of this year, I became ill for a couple days, had a fever, some muscle aches, just kind of laid around, felt miserable. And then all of a sudden I had this rash break out on my left forehead, and within 24 hours developed the fairly typical lesions that you see with shingles, and unfortunately had the full-blown event. Most people don't know the first couple days, but then once the rash breaks out and the pain comes on, then most people figure out, they have shingles. And so I called my physician, and he did start me on some antiviral oral medication. So it is important to start the oral medication to decrease the severity and the length of the illness. And the most common and the most miserable complication of shingles is the postherpetic neuralgia, where the nerve root remains inflamed even after the skin is cleared up. And that's the complication that you really want to avoid, is the postherpetic neuralgia. So I did have the vaccine about 6 months prior to having shingles, and the intent of the vaccine is to reduce the severity and length of the illness if you get it, or eliminate it entirely. But people can get shingles after having the shingles shot, which I did, but I did not have the complication of the post-herpetic neuralgia, which I'm very thankful for. So within a couple weeks, the skin lesion I had cleared up, and I feel fine again. You carry that virus in your body from chickenpox when you're a child, and then it reactivates or just comes back out as the shingles. So you harbor that virus in your body your entire life. And I think there's several things that can set it off. Sometimes it's illness, stress, physical exhaustion, things like that can be factors that set it off. The intent is you have the shingles shot. You hope you never get shingles, but you can. Once you've had shingles, you can get them again, but it's pretty rare to get them, a second or a third time. We do recommend anyone over the age of 50 get the shot. And if you have symptoms, call your doctor and get started on the antiviral treatment or oral medication as soon as you can.
Thank you, David. The older you are, the worse it can be. The post-herpetic neuralgia is the worst part. So, certainly I jump on it when it's an older patient in particular.
Although 50 is not old, It's just, strange. 50 should not be considered
very young
old,
guy, very young.
The closer you get to it, the less old it seems.
Yes.
So, we were talking that 1 in 3 people in the United States will get shingles. There's 3 of us here, and I've actually had shingles.
And you've had it.
I've had it, unfortunately. The situation was that I was actually traveling in India, and I'd been on a long road trip, and I started having this pain in my side, and I thought it was just I'd been sitting all day, maybe that's why it was hurting. I put a warm pack on it, and within a few minutes saw this horrible rash, and so I knew right away what it was. Went and got an antiviral right away and started treatment immediately. And I was also very fortunate, like the case that was presented, in that I did not develop the post-herpetic neuralgia, but it is a very debilitating condition for people to have. And the vaccine, while it's not 100% protective, is protective, and it should be given to anyone who's over 50, really.
I've heard that it reduces the incidence of shingles in half. And if you do get the shingles, it reduces the severity in half. Now,
the severity and the duration of
and
the
I think
illness.
the chances of getting post-herpetic neuralgia, which can be very disabling and very painful, So
and higher incidence as you get older.
Yeah, and
Right.
Dr. Erickson, fortunately didn't get that because he had the vaccine before,
There we go.
I think in our discussion we have talked about the immunosuppressed patients, So I think patients who are immunosuppressed, if they have an organ transplant or on any immunosuppressive medications due to any reasons, then I think even before 50, they can have it. And they actually can have a very severe form of it. It could be disseminated, Okay. So I think in immunosuppressed patients, it could be very severe,
Yes, important lesson. This is your show. Your questions are key to our show discussion. Call in your questions at 1-888-376-6225 or send us an email to ask@prairiedoc.org. My batteries, I've got a question here. It says, 63-year-old man asked, please discuss enterovirus.
Okay, I'm happy to discuss it.
That sounds like a GI diarrhea.
It's not commonly actually associated with diarrhea necessarily. Some enteroviruses are. So enteroviruses belong to a family of viruses, actually. Some people don't know that the polioviruses, for example, belong to that same family. But enteroviruses commonly in children cause things like hand, foot, and mouth disease. They can cause fever, illnesses, meningitis, lots of different manifestations that we see from enterovirus infection in children. In adults, they can cause very similar things, actually, particularly as we were talking about in people who have underlying medical conditions, who are debilitated in some way, who have immune deficiencies that they've developed. Enteroviruses can cause pretty serious infections.
We got so many viruses out there that it can be anything and everything, can it not?
Yeah, I think pretty much, most of the organs can be infected, and diarrhea, respiratory illness, meningitis, pericarditis, a broad range of, infections, from
anything, arthritis.
But you don't generally die from it unless you're very immunosuppressed.
Unless it's AIDS.
In children, the deaths occur actually in children whose mothers get enteroviral infection shortly before they deliver.
Oh, okay.
What happens, and that is a very dangerous situation, because what happens in that situation is the mother is infected, has no immunity, passes a boatload of virus to the baby. Baby has very little defenses themselves when they're born. They develop what we call a sepsis syndrome, and they have a very high mortality.
Dr. Chatterjee, there is no antiviral treatment for this?
Unfortunately, there is not. There were a couple of antivirals that were developed in the 1980s and 90s, but then they had so many adverse effects, and it just didn't pan
And
out.
antibiotics don't work definitely on this.
Antibiotics do not work for
Nothing
any
for
viruses.
It doesn't
It's
treat the
not true.
cold.
There are some antiviral medicines that work for certain viruses, just not for this one.
This one, yeah.
Can shingles be passed through a blood transfusion?
Well,
Jawad.
that's a tough question, but I think it can be. Yeah, I think many viruses can be
Carried in the blood.
Actually, I had a case where West Nile was transmitted through blood transfusion, so I cannot rule it out completely.
It's very unlikely to be, because this is a virus that actually travels along the nerves. In cases of chickenpox, there are two times when it goes through the bloodstream. We call it a primary viremia and a secondary viremia, but that's in children who get chickenpox.
Right. So chickenpox, though, can be spread.
Yeah.
The virus.
Yeah, if you had a child who, for some reason, was donating blood, you might get it from there. But in general, it's with someone who has shingles, that virus, unless they have disseminated disease, in which case they'd be very sick,
With organ
they would not have
transplantation,
it.
I think if they have an active disease and organ transplantation.
That again may be a possibility,
Very rare
but
possibility.
it's extremely rare.
Yeah,
It's extremely rare.
Interesting.
It
So
doesn't
when they're
go through
down-
the bloodstream.
Yeah.
No.
Okay.
No.
Do we need to use antibiotics before dental work if we have had a joint or heart valve replaced? That's a good question. What's the answer to that?
Well, I think the recent guidelines suggest you should not. I think this is one of the common
This is an old
questions.
one.
We're getting a joint. Actually, I had this question today. Somebody getting a joint replaced, and his surgeon is recommending 3 days of antibiotics. And they can end up with C. diff. So I think there is no evidence that taking antibiotics before the orthopedic procedure will lead to a decreased risk of infection involving that processes. Also with the heart valves, unless they have history of congenital heart disease, or prior history of endocarditis, unless they have that complicated history, I think it's not recommended based on the
So
recent
Big
guidelines.
bad heart valve is another story.
The American Heart Association actually publishes guidelines based on scientific studies and evidence as to which patients should receive antibiotics if they are going to have dental procedures. And typically when we get calls on this from primary care physicians, that's what we go to say, in
What
this
is it?
situation
What
you
does the
need
book
it,
say?
and in these situations you don't need it.
66-year-old woman from Huron has a boil and diagnosed staph, and they put her on Bactrim twice a day for 30 days. Was that a good approach?
That's too much.
Too long.
Too long. Especially in someone who is immunocompetent may not actually need any antibiotic. And
You drain it.
That's correct.
So I think 30 days is just a very long duration. And
For
Bactrim is not a safe drug. It has a lot of toxicities. It can affect your kidneys. Your
Suppress
bone marrow.
the bone marrow.
Yeah. So that's too
So
long
for
of a
skin and
duration.
soft tissue infections, typically we will recommend between 5 to 7 days of antibiotics at most, if antibiotics are needed
It's
at
changed.
all.
It used to be 10 days for everything,
And unfortunately, we went to that with not much evidence that was required.
Well,
So I think
but it was the law. It was the way we had to do it.
If you need them 5 to 7 days max, I think not more than that.
I've often thought that Bactrim was one of the underutilized drugs because it's so effective and it works well for staph and MRSA, actually.
Yeah.
We actually use quite a bit of trimethoprim sulfamethoxazole, and in fact, in developing countries where it's a cheap, inexpensive antibiotic, it's
good
used
choice.
a lot for treating urinary tract infections, for treating skin and
It's
soft
one of
tissue
my favorite
infections.
words, trimethoprim sulfamethoxazole.
Yeah.
69-year-old man from Sioux Falls, our physician guilty of using too many tests and broad-spectrum antibiotics in general. Physicians guilty of using too many tests and broad-spectrum antibiotics in general. What did you say? Yes, we probably
We
are.
were talking about this earlier, that
To the meds, to
there is a Choosing Wisely campaign which the American College of Physicians has developed and actually is being adopted in other countries. I just found out that in Canada there is a Department of Pediatrics at Sick Kids in Toronto that's using it. It's basically to minimize unwanted, unneeded tests and treatments that don't help the patient, that really don't improve the quality of care, and do, in fact, put the patient at risk for adverse effects, and of course add to the cost.
Add to the cost.
Yeah.
Let's ask the elephant in the room too, and that is the use of antibiotics in animals. Veterinarians have now they've changed things radically and said, no, you can't feed antibiotics to herds unless the veterinarian writes the prescription. And one of the reasons we've always said that the majority of antibiotics prescribed in this world are with animals, but one of them is really a pro-bug encourager on an animal that has multiple stomachs, that type of a thing, and it really isn't an antibiotic, doesn't count. On the other hand, I sense that there's still excessive use, and you know, the data that says that doctors will prescribe an antibiotic if parents want it 63% of the time and won't if the parents don't care 13% of the time, so will that happen with the veterinarians? What's your comment about that?
I think it's a different issue with animal husbandry. A majority of antibiotics that are used in raising animals are really for growth promotion, and that's what we think is not appropriate. Obviously, if animals are sick and need to be treated, they should be treated if they have an infection, and that's under the care of a veterinarian. The WHO actually has published a list of antibiotics, they've been doing this since the early 2000s, of antibiotics which are important for human use where we don't have lots of different options. Fluoroquinolones actually top that list, cephalosporins, glycopeptides. These are classes of antibiotics where we don't have much in the way of choices, what Dr. Nazir was talking about earlier, where you have infections, we don't have any antibiotic left to treat them with. So the WHO, the World Health Organization, really wants us to restrict the use of these antibiotics, particularly for growth promotion purposes.
Yeah, I completely agree. I think for the growth promotion, you have to be very careful, and I think it has impact on resistance in human beings also, and then we end up with organisms which are multi-drug resistant,
But you can't blame the farmer for wanting to have a productive herd and that does well, and that's on his or her mind, and you can't blame him for pushing for it, but the reality is there's danger out there from this.
Yeah.
And
this
we
is a
have to
public
push for
health
it.
risk.
I like the
requires
idea.
a lot of education, at that level. Yeah.
I like the idea of encouraging grocery stores to say, this is antibiotic-free, never had antibiotic-free chicken. This is antibiotic-free turkey. These are antibiotic-free beef, and promote that. And we'll pay a little bit more, but I think it's worth it. And I don't want to offend farmers. They work very hard. The last thing I would want to do is the wrong thing in that. I'm very sensitive about this issue. It's just that it's a human it's a physician and a veterinarian issue that we need to be very conscious of.
I think it's important to raise awareness about this issue at every level. Yeah, so.
Caller has friends that won't vaccinate their children. Do you have advice on what I should say to them to convince them?
We have a show that's only an hour long, and we probably need several hours to deal with this question. No, but I think addressing this in context is important. So certainly there are people who do not want to vaccinate their children and do not want vaccines for themselves. The data show it's less than 1%, first of all, of people in the United States that feel that way. So that's the first thing.
It's not that many people.
It's not that many people. The other thing is a lot of them are what I call the worried well. So these are people who have concerns. They've seen something in the media. They've heard something somewhere about vaccines being associated with adverse effects, which are not based in fact at all. They're not based in science. These are myths that have been propagated over time. I don't even mention the myths because then people immediately start thinking that that's what's going to happen. There's a small proportion of people who, despite all the scientific evidence that you provide, are convinced and are not going to change their mind. And what we advise pediatricians or the primary care folks that are taking care of children to do is to work with the families as much as they can, to be open-minded, to ask questions to see why they're concerned, what their concerns are, and if they can actually address them. Right. Then that is the best way in my mind to deal with it, recognizing that there's going to be a small proportion who are not going to be convinced no matter what you show them.
Somebody's plotting against them, and there it is.
Yeah. And if they get convinced, down the road, there's always a catch-up schedule which, can be utilized to do the
Absolutely.
vaccinations.
This is why the American Academy of Pediatrics recommends that you maintain a relationship with the family
patient,
so that you have opportunities down the road. And I've actually personally experienced that, where the first time I met a family that had not vaccinated their child, they said, absolutely not, we're not going to do it. And, the next time I saw them, I said, have you reconsidered, and, would you like to at least have your child receive one of these vaccines? So sometimes you have to break up the schedule in a way that is acceptable to them. It's not ideal. It does place the child at risk. They remain at risk. They put other children at risk, other adults at risk. But you do the best you can with these families.
I think that's the take home. The reality is you don't get a vaccination for you. You get it for all those people who might be affected. 57-year-old man, real quick, dad had MRSA multiple times, numerous joint replacements on antibiotics all the time. Provider cut antibiotics in half. MRSA came back. Going forward, is it more beneficial to keep on antibiotics or to cut in half again and risk the return? That's a toughie.
That's a tough, but I think, when you cut antibiotic in half, I think you are doing something, you're not clear what you're doing, not getting an optimal dose, or you're treating or prophylaxing, and there's not much evidence, with that approach, So I think if someone is getting recurrent, infections, you have to kind of take a step back and see why that's happening, if there's a complicating factor, what's the nutritional status, what's the blood supply to that site, So you have to take a bigger picture, take a step back, try to evaluate the reason of recurrence rather than continuing the antibiotics.
And I would say that a lot of leg ulcers, a lot of leg infections, people with diabetic
may not have blood supply, which needs
you
to
will
be fixed.
never get them healed until you get a blood supply. Forget about it.
Yeah. So I think in our fellowship, our mentor asked this question. What is the number one reason why antibiotics fail? And the answer was if they're not able to get to the site of infection. That is the number one reason for antibiotic failure.
All right, quickly, man from White Owl, how can C. difficile cause pseudogout, and what are the treatment options? I haven't heard of C. difficile causing pseudogout.
I have not heard about that too.
Have you either?
Yeah.
Pseudogout is just a kind of an inflammatory joint problem.
Maybe they had pseudogout and C. diff at the same time, but I don't know if there's an association with it.
I always worry that they might have an infection in the joint. But C. difficile, I don't understand that one. 76-year-old woman from Ipswich. My husband, I love that word, Ipswich. My husband had to pay $138 for DT and whooping cough vaccine. Where can adults get free immunization? And 90-year-old woman from Sioux Falls asks, why are shingle vaccine not paid for by insurance? So ideas about payment?
They're complicated for adults. For children, there's a Vaccines for Children program, so all children through the age of 18 can get all of their vaccines paid for. For adults, there's probably more problems. I would recommend that they contact their county public health office to try and get that.
And now for the winner of tonight's Prairie Doc quiz question. True or false? After regular flu shot, those older than 65 produce 50 to 75% less antibodies to flu than do younger folks? The answer is true. It was Bruce Goldman who answered the question correctly. Thank you, Bruce, for participating, and a book will be in the mail to you soon. So a high-dose vaccine has been developed to try to solve that problem because older people don't have an immune system, but there's some questions about whether it has more side effects and whether it's worth it. Are you recommending, you're the adult doctor,
I think I'm recommending it. I think, in
high dose and
I think you get a better immune response, and that's more protective to prevent the infection, So I think at Avera and the hospitals we practice, we make that recommendation, for patients above 65 to get high dose,
Okay.
Yeah, in terms of the reactions, it is true that there are more side effects at the injection site.
Yeah.
But other than that, there are no more reactions.
All right, we'll be right back after this.
Good day, citizens. It is with regret that I inform you that the end is near for me. I'm old, I'm tired, I'm weak. But don't go thinking that you've won the war against the flu. Before I go to that big petri dish in the sky, I will find a suitable replacement. Be warned.
With the advent of antibiotics in the 1930s and 40s, we saw a true change in longevity and a reduction in premature death from infectious diseases. Now we're seeing deaths from bacteria which are resistant to every antibiotic, and it's not just the sick and decrepit who are affected. Recent studies show many more people are dying in the U.S. from antibiotic-resistant bacteria than from AIDS. It's a real crisis from too much of a good thing. Resistance is due to excessive and overuse of antibiotics, which are often incorrectly seen as the cure for whatever ails us. The most glaring example is when antibiotics are given for what is obviously the common cold, making absolutely no difference in the course of that illness. Often I hear from the patient, why not start an antibiotic to keep those viral bronchitises from turning into pneumonia? To that question, I usually answer, you are correct. When bacteria pneumonia occurs, it often follows a common cold. But studies show antibiotics don't prevent that pneumonia following the cold. It just becomes a pneumonia resistant to treatment. So why are we overusing antibiotics? Certainly, an effective sales effort by the pharmaceutical industry is part of it, but what's most to blame is probably patient or parent expectation. One study showed that 65% of the time children get antibiotics if the doctor perceives the parents expect them, but only 12% of the time when antibiotics are not expected, even when the children are similarly ill. Ultimately, the doctor is responsible, but too often influenced to provide unnecessary treatment. Another huge reason for growing antibiotic resistance has resulted from past regular use in animal and poultry feed, which boosts growth and profits. Now that's being limited for use only when a veterinarian prescribes them. Also, there is strong encouragement for veterinarians to prescribe the newer, broader spectrum antibiotics only for the care of a sick individual animal, not the herd. These new moves are a start, but monitoring of reduced use needs to occur. The good news is that in countries where efforts to use less antibiotics are successful, then over just a few years, antibiotics become effective again. So there is something very important you can do. First, never push your doctor for an antibiotic. Make it clear you would be happy without the stuff unless it's necessary. Second, please push your grocery store or your restaurant for antibiotic-free meat. If we're willing to pay a little more for antibiotic-free products, farmers will provide. Let's not take antibiotics for granted. By avoiding the overuse of antibiotics, we can save ourselves from a real crisis. Well, a great big thank you to our guests, Archana Chatterjee and Jawad Nazir. Thank you both very much.
Thank you very much for inviting us.
Great information. A final note on Zika in South Dakota. Through the end of September, South Dakota had reported 2 Zika cases, both travel-related. This summer's surveillance found none of the Aedes albopictus mosquito that is the potential transmitter of Zika. With the colder weather, we should be okay unless we travel to places where it is still being transmitted, and many of us probably will. The cold weather does signal a season change, and as far as flu is concerned, we reported our first lab-confirmed case last week, an influenza A in Pennington County, and also the first flu-related hospitalization in influenza B in Potter County. It is here, folks. Do not delay. Get your flu vaccine now. Reduce your chance of catching the flu bug this season. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Hipsters, hippies, hippos? No, even better, it is our own marvelous hip. Next time on Call with the Prairie Doc.
Well, welcome to On Call with the Prairie Doc After Hours. We couldn't get to all of the questions, so we're going to finish them here. You can look at them online, and thanks for your calls and questions. 75-year-old woman from Sioux Falls, could you discuss reactions to antibiotics?
Yeah, I think, the reactions, this is a very good question, because they're not multivitamins, so there's a broad range of toxicities, which can happen, with antibiotics. The most common we see is like a rash or a diarrhea, which could be self-limited, stop the antibiotic and it gets better. But sometimes there could be organ damage, it can affect your kidneys, putting you into dialysis, it can affect your liver, causing failure, suppress the bone marrow. So those are more serious reactions, and some antibiotics can do that.
Throw also a fever, so that you think there's an infection.
Drug fever
it's
is
a drug
also
fever.
possible, yeah.
Dr. Holm, one of the most serious cases of Stevens-Johnson syndrome that I saw, this is a very severe allergic reaction, was after this patient had taken one pill of trimethoprim sulfamethoxazole, the Bactrim we were talking about earlier. So there can be very, very serious consequences with a single dose. Did the person survive? That patient was a 19-year-old. He did survive. He lost almost 80% of his skin. He needed skin grafting, and he was in the hospital for almost 6 months.
And of course, you think the mouth was sore too. I mean, they shedded all of the lining of his mouth. I mean, it was
his eyes, his mouth, his whole GI tract. This was an incredible case. Yeah.
A woman from Ute, Iowa. She took an antibiotic and then took a probiotic to help prevent problems. Should she take a probiotic all the time? Let's talk about probiotics. What are options? What is cheaper? Activia. What first of all, do you believe in probiotics? I see you're nodding yes.
I think I'm kind of, I've not seen too much of a good evidence to see that it helps, but I think I've seen patients, who use it and they feel better, So I think because there's not much evidence, I don't know if you're aware of much evidence.
Yeah, so there actually is evidence, and in fact I have worked with some probiotics when I was still running a lab while I was at Creighton. So they have been shown to reduce antibiotic-associated diarrhea. They have been shown to reduce the duration and severity of diarrhea that's related to rotavirus, which used to be a very common cause of viral diarrhea in the United States. We now have a vaccine for it, so we see very little of that. So there are specific situations in which probiotics are effective. I think you have to be careful about all the claims that are made about different probiotics. They don't necessarily have to be very expensive ones, but it's important to know your probiotics just like you want to know about your antibiotics.
Right.
I think in the adult population, we also have to be careful. Sometimes patients are very immunosuppressed, so there could be adverse consequences of it too, So,
so we
and
have to be
there are reports of actually the bacteria that are the good bacteria in probiotics getting into the bloodstream and causing bloodstream infections and things like that.
It depends on the
so
patient, the type of infection,
The best advice is to speak to their primary care provider about taking these before they take them.
I do know, and some of the supplements doesn't have any of the ingredients it promises that it has, but so it's good to have USP, like Nature Made. High V acidophilus, for example, is a probiotic that's inexpensive. Activia, the yeast, the yogurt. That was the studies that came out, and I was at a ACP national meeting, and there was 3 people who quoted the Activia yogurt study done by the people who sell Activia. But
yeah, and so that's why you have to be a little bit careful about what evidence you accept. But these are the 2 areas that I'm aware of where probiotics are actually effective.
We didn't make a great answer there, but it was a kind of wishy-washy answer, but that's as good as I think we can do.
Yeah, I think, as Dr. Chatterjee said, certain situations, it can be, and I think in adult, in immunosuppressed, you have to be really careful, with that.
92-year-old asks, after a flu shot, a bruise appeared. Is this common? Are there ways to prevent a bruise from a flu shot?
Yeah, we were talking about that earlier, that the most common reaction we see for injectable vaccines is an injection site reaction. Pain, swelling, redness, sometimes a bruise at the injection site. I think one of the common things I've seen our nurses doing is to put pressure on the site so that there is less bleeding. The bruise happens because there's bleeding on that site. Sometimes you will see people that have received an injection rubbing that site. That's actually not a good thing to do because if you rub it, you're likely to cause more bleeding in that site. But in general, these are not common reactions at all.
67-year-old woman from Sioux Falls, how can you get MRSA in the hospital?
Yeah, I think there is a higher chance of getting MRSA in the hospital if you are hospitalized for a long time, or if the hand hygiene principle is not followed in the hospital, because in hospital we see more patients who are more sick, or who are in the hospital for a longer period of time,
immunocompromised,
who have been on
worse bugs.
antibiotics, so I think they are kind of what we use colonized, with MRSA and other resistant bugs, so it can be transmitted, from one patient to another, through a healthcare worker or through family member or somebody. Yeah.
I think the most important thing that patients can and their families can do when they have a family member in the hospital is to ask the healthcare providers that are coming through, anyone that's entering that room and exiting that room, whether they wash their hands or clean their hands with hand sanitizer before they come in, and to observe them.
Yeah.
Be proactive.
Yeah.
It's not a bad thing. In fact, I would say that all good hospitals actually encourage their patients to remind healthcare workers
And
that they
that
need to do
culture is
this.
somewhat lacking in South Dakota, but I think it's a good thing for the patients to be proactive for their rights, and
Foam in, foam out.
demand it,
Yep.
So, yeah.
Demand. Foam in and foam out. Put your hand in.
It can be asked very respectfully to say, I didn't see you wash your hands. Are you sure you did? It's just a reminder. It's not a bad thing to do at all.
Yeah.
How many times or often do you need a pneumonia or shingles shot? And also, I'm a 52-year-old, had shingles about 20 years ago. Should I get another shingles shot? And the answer is yes, get the shingles shot.
Yes, because
How
20
many
years
shingles
ago there was no shingles shot available at that time.
Right.
So
How many shingles shots should he get?
Only
The
recommended.
shingles vaccine is only recommended as a single dose at this time. The pneumonia vaccine is recommended at this time. The 2 doses are recommended the first time it's given. For people who have underlying medical conditions, they may need another dose of the 23-valent vaccines 5 years after the initial dose is given.
Last question. 70-year-old woman from Sioux Falls had a heart attack in May and is allergic to eggs. Could she still have the flu shot this year? Allergic to eggs?
The answer is yes.
Yes.
The CDC has said very clearly that allergy to eggs is not a reason to not vaccinate for flu.
So this year CDC has updated its recommendations regarding egg allergy, and I think that's what exactly Dr. Chatterjee is saying. It's not a contraindication. And if someone is very nervous, they can use Flublok, which is an egg, free vaccine. So there's no reason they should not get it.
Get the flu vaccine.
Get that flu shot.
Absolutely.
All right. Well, thank you both
Sure, no
so
problem.
much
Thank you
for
very
being
much as well.
our guests tonight, and thank you for listening. Until next time, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
The South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health Systems, Ophthalmology Limited, South Dakota State Medical Association,
Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision,
Aberdeen Asthma and Allergy, Black Hills Medical Society, Dakota Bank,
Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Regional Health, and Swiftel Communications.